Ma'am and dear friends, very good afternoon to all of you. At the outset, I'd like to thank Dr. Santosh Wanavar and AOS team for inviting me here today to speak to your key points in the management of uveitis. Slides are not moving. Yeah. We follow the stepwise approach in the management of uveitis. That is, as soon as when the patient walks in, we observe them, and that itself will give a clue what are the associated systemic disease the patient might have. First, detailed ocular history, then complete ophthalmic evaluation, which includes dilated fundus examination with scleral indentation, then systemic evaluation. We'll do a naming and meshing. Accordingly, we order relevant investigations and start the patient on appropriate management. If the patient is refractory to treatment or not responding to the treatment, we'll re-investigate again and change our treatment plan. So this is the way we work on it. What are the algorithms is available? Broadly, we divide the uveitis into infectious or non-infectious uveitis. It's important that we need to treat infectious uveitis with appropriate antimicrobial therapy. If it has a bacterial infection, we treat them with antibacterial agents. The commonly one is ocular tuberculosis. We treat them with antituberculous therapy, 9 months course commonly we follow. Or if you have a syphilis, we treat them with antisyphilitic treatment. Next comes the viral. It could be due to herpetic viruses. In that, we treat them with acyclovir. It could be in the form of topical or systemic therapy. If it's CMV, we treat them with ganciclovir, intravitreal or systemic ganciclovir therapy. If it's antifungal, fluconazole, itraconazole or other antifungal agents including amphotericin B in severe candidiasis. Next, antiparasitic albendazole is also used. More importantly, in infective uveitis, in addition to anti-infective therapy, we also treat them with anti-inflammatory such as corticosteroids to control the eye inflammation in majority of the infective uveitis. Next, we'll move on to non-infective uveitis. Coming to the non-infective uveitis, the corticosteroids is the gold standard in controlling the inflammation. It could be in the form of topical or systemic, periocular or intravitreal steroid implants. In the systemic, it could be in the form of oral or intravenous methylprednisolone we give. Next comes immunosuppressive. In the immunosuppressive therapy, commonly we use the drugs are methotrexate, azathioprine, mycophenolate meftil, or T-cell inhibitors like cyclosporine, cyclophosphamide, and tacrolimus can be used. Next comes the recent drugs such as biologics. In this, we use infliximab, adalimumab, etanercept, or rituximab. Depending upon whether it's T-cell mediated disease or B-cell mediated disease, we choose the appropriate biologic agents. The recent drugs are Janus kinase inhibitors. Drugs like tafasitamab and baricitinib are also used to control the inflammation. The next is role of periocular steroid injection. Here, commonly what we use is a Smith and Nozick technique or orbital floor injection. Here, the periocular injections to be avoided in a case of an infective uveitis, especially conditions like toxoplasmosis or necrotizing retinitis. Next is viral uveitis. Viral, we diagnose based on the clinical presentation. Can have diffuse pigmented keratic precipitates across the cornea or atrophic patches of the iris with increased intraocular pressure. We make the diagnosis based on the clinical presentations and treat them on appropriate antiviral and anti-inflammatory therapy. Coming to the posterior segment manifestation, this is an emergency. You have to dilate and see the fundus, otherwise many times you may miss acute retinal necrosis, what is happening in the retinal periphery. ARN is called Swiss cheese pattern. CMV retinitis, what we call it as a pizza pie appearance or tomato ketchup appearance. PORN is a cracked mud appearance. So we make the diagnosis based on the clinical presentation and start the appropriate antiviral therapy at the earliest without waiting for the lab investigations, especially in necrotizing viral retinitis. Corticosteroids should never be started without appropriate antiviral cover in these entities. The next we'll move on to toxoplasmosis. Toxoplasmosis is the commonest cause of infectious posterior uveitis across the globe. And they have classical presentations like head light in the fog appearance. These lesions can occur adjacent to the previous scar or somewhere in the fundus. We make the serological diagnosis, IgG and IgM, or in apical presentations, molecular diagnostic like this B1 gene for toxoplasmosis is useful. In this entity, we start the patient on anti-toxo treatment followed by systemic steroids. 4 weeks we'll give, and depending upon the response, we stop the systemic steroids and anti-toxo treatment to be continued. The next we'll move on to tuberculosis. Tuberculosis have granulomatous panuveitis. What we commonly see is a retinal vasculitis. Here we could see a scar along the vessels could be one of the clinical clue to pick up tuberculous vasculitis and also differentiate it from sarcoidosis. Anterior segment, they can have broad-based posterior synechiae. They have peripheral vasculitis, and FFA is important to map out the areas of capillary non-perfusion. We treat them with ATT, systemic steroids, and laser photocoagulation if there is a capillary non-perfusion areas in the retinal periphery. We order MAN2, chest X-ray or HRCT. HRCT is more sensitive, and quantiferon TB gold test. If we have a lymph nodes, we can do the biopsy. From the ocular fluid, we can do a PCR for tuberculosis, that is MPB64 or IS6-1110. Here, based on that, we can have a confirmed diagnosis or presumptive diagnosis. Recently, COTS calculator is available. In that, if we feed the data, it gives us the possibility of the tuberculosis. Most of the times, it is presumptive so that we can convince the physician to start the patient on anti-TB drugs. Next, we'll move on to syphilis. Syphilis is a sexually transmitted disease. It has a great masquerade. It can mimic any type of uveitis. You can put them in the differential diagnosis. In common, classically, the posterior ones are placoid chorioretinitis or triangular patch of retinitis or punctate inner retinitis. These three, whenever we see this particular pattern, we need to suspect syphilis. We order both non-specific and specific tests for syphilis, that is TPHA or FTABS in specific, or VDRL or RPR. After making the diagnosis, we have to start them on systemic antisyphilitic treatment with penicillin. The next is, what are the things we need to rule out the differentials? Here, uveitis can mimic other uveitic entities like masquerades. That is uveitis in extremes of age group, retinoblastoma in children and masquerades in older age group, or posterior scleritis. Here the patients will complaining of severe pain, excruciating pain. It wakes them up from the sleep, and they can have classical, what we call it as a subtenon's fluid or T sign. Based on that, we make the diagnosis of posterior scleritis. Next, other entity is multiple cotton wool spots in the fundus, could be secondary to systemic diseases like hypertension, or if we have multifocal CSCR, it is important to differentiate from other exudative detachments like VKH, because if you start steroids, the patient is going to worsen. In uveitis, the corticosteroids is the treatment of choice. In CSCR, we tend to avoid corticosteroid therapy. Coming to the take-home message, in uveitis, we need to do the detailed history, complete ocular examination, that is dilated fundus examination with scleral indentation, and we have to pick up the clues, both ocular as well as based on the systemic examination. If you are not sure, better not to start the patient on oral steroids, and we have to avoid inappropriate and inadequate therapy. And also we have to watch out for development of complications like cystoid macular edema, choroidal neovascular membrane in uveitis. So once we recognize the complications, we need to address the complication, and we have to pick up masquerade syndromes because the management is going to be different than the uveitic entities. Thank you for your attention. Any questions, I'll be happy to take them.
Thank you, madam. Very nice.